You're most welcome at Medical Sciences Made Easy. And today's session we want to discuss about anxiolytics, or what we call anxiety and insomnia. Anxiety, we are going to see it is a condition or a central nervous system condition due to the defect of limbic system. And within the limbic system, we're going to see we have two pairs of amygdala. And this amygdala is the one that is responsible for storage of memories. So in case you have bad memories, traumatic memories, they are stored within amygdala, which is the right and the left. But we're going to see the left is the most affected, which is predominant in women. And we're going to see women are more prone to anxiety compared to men due to the predominance of the left amygdala. So as we begin, we urge you to subscribe to our channel. You can like the video, then share your comments in the comment section, and so sharing the link to others. So anxiety, it is a state of worry or nervousness, which is characterized by trembling, increased sweating, increased heartbeat, and respiratory rate. That is what we call anxiety. And people become anxious, or they portray anxiety when they face some challenging situations due to stress, or which causes the defective or the dysfunction of the limbic system. As we know that in the central nervous physiology, the limbic system is made up of the hypothalamus, it has the hippocampus, then it has what we call the amygdala. So we're going to see that this anxiety, in the normal physiology, we're going to see that this limbic system, which contains amygdala, which we have said it is two pairs, they are always moderated by two neurotransmitters, that is GABA and serotonin, which we know as 5-hydroxytryptamine. These are the two neurotransmitters. 5-hydroxytryptamine, that is serotonin. These are the neurotransmitters that enable the functioning of the limbic system, which we have said that the amygdala part is responsible for memories. Whenever you have good memories, bad memories, they are kept within that system. So what causes anxiety? We are going to see, in case there is low levels of GABA, which is inhibitory, together with the serotonin neurotransmitters, when they decrease in the CNS, they cause, or they are going to depress, or they will not stimulate hypothalamus. So we're going to see that the stimulus from the limbic system, either it moderates what we call, can moderate the medulla oblongata, or the hypothalamus. So when the medulla oblongata receives information from the limbic system in the presence of GABA and serotonin, it is going to stimulate the pituitary gland, that is the anterior pituitary gland, to release what we call ACTH, that is adrenocorticotropic hormone, which goes to the adrenal gland. And when it reaches in the adrenal gland, it stimulates release of cortisol. Cortisol is released, and the cortisol is also responsible for increasing fight and flight. Whereas when the neurotransmitters goes to the hypothalamus, in the hypothalamus region, actually this medulla is the one that controls the sympathetic. This is the part of the sympathetic. This one is going to stimulate the sympathetic nervous system, which will increase fear or fight and flight. For example, when it goes to the eyes, it is going to cause eye dilatation. When it goes to the heart, it is going to increase heart rate and increase blood pressure. When it goes to the lungs, we are going to see in the lungs it is going to increase breathing rate or respiratory rate. When it goes to the muscles, it is going to increase contractility of the muscles, muscle contraction. When it goes to the skin, it increases sweating. So those are the mediations from the medulla oblongata. Then to the hypothalamus, it releases what we call adrenocorticotropin releasing hormone. And this adrenocorticotropin releasing hormone stimulates the anterior pituitary gland to release ACTH, adrenocorticotropic hormone, which stimulates the adrenal cortex, to release cortisol. And also this one increases the state of fight and flight, emergency situations. So this is the normal functioning of the limbic system in the amygdala region, whereby the stimulation of the amygdala is going to cause the the sympathetic nervous system to increase dilatation of the eye, to increase heart rate, to increase breathing rate, to increasing blood pressure, increasing muscle contractility, increasing sweating, and so forth. Then the cortisol is also released so that we can produce enough glucose to run away from these stressful situations. So that's why we are seeing when we have the serotonin neuron, serotonin, when it is released, it is the one that stimulates. It stimulates the GABA neuron in the central nervous system to release GABA neurotransmitter. And when GABA neurotransmitter is an inhibitory neurotransmitter, when it reaches on the neurons of the sympathetic nervous system, it inhibits. For it exerts inhibitory effect. And this inhibitory effect is the one that brings about these reactions in the normal condition. But now we are looking at the opposite. In case there is low levels of serotonin, meaning GABA neurons are not stimulated, and when GABA neurons are not stimulated, we shall see low levels of GABA neurotransmitter. And when GABA neurotransmitter is low, meaning the sympathetic nervous system are not going to be inhibited. And when they are not inhibited, they are going to be stimulated to increase the heart rate, increasing the breathing rate, increasing the muscle contraction, leading to the state of stressful situations like anxiety, which we are calling anxiety, which is characterized by depression, it is characterized by trembling, characterized by increased sweating, that is the diaphoresis, and fear or increased heart rate, or what we can call tachycardia. So we are going to see that what is causing anxiety is low levels of serotonin and low levels of GABA, whereby when there is no GABA, then this GABA, which is responsible for inhibiting, when it is not there, these ones are stimulated. They are stimulated. But if GABA is enough, it is inhibited. So we are seeing when the GABA is low, the central nervous or the sympathetic nervous system neurons are stimulated. They are not inhibited, but they are stimulated. And when they are stimulated, they bring about these events which result into anxiety. So that is the pathophysiology of anxiety. Whereas insomnia, for insomnia, we are going to see this is failure of having sleep. So there are people who normally complain that when they go to the bed, they fail to get sleep, and that is what we regard as insomnia. It can be chronic, whereby every time someone wants to sleep, they fail, they keep asleep for the whole night. And what is the pathophysiology behind that? The normal physiology, we know that the pineal gland releases melatonin hormone, and this melatonin hormone, it goes to the suprachiasmatic nucleus. It goes and inhibits suprachiasmatic nucleus within the hypothalamus. And when this suprachiasmatic nucleus in the hypothalamus is inhibited, it is going to go and stimulate sleep. This one stimulates sleep. At the same time, it inhibits arousal. So it stimulates sleep, then inhibits wakefulness, or it makes you to feel like you want to be asleep. So this is so in presence of insomnia, we are going to see that low levels of melatonin hormone, when the pineal gland is not producing enough, there is a decrease in the melatonin hormone. A decrease in the melatonin hormone, it will not exert the inhibitory effect, so it will fail to inhibit suprachiasmatic nucleus within hypothalamus. And when this suprachiasmatic nucleus is not inhibited, or when it is stimulated, so when it is stimulated due to lack of serotonin, we are going to see this one stimulating also sleep and inhibiting wakefulness. So this is the pathophysiology behind insomnia. So insomnia is majorly due to low levels of or lack of melatonin. And when there is no melatonin, then there will be, when there is no melatonin, if the levels of melatonin are low, we are going to stimulate suprachiasmatic nucleus within the hypothalamus, which is going to inhibit. It is going to inhibit sleep. That is low levels of melatonin, and it is going to stimulate you to be awake. That is when melatonin is super low. But when it is enough, it is going to inhibit this nucleus, and when it is inhibited, it stimulates sleep and inhibits wakefulness. So in summary, we have seen anxiety, low levels of serotonin and low levels of GABA. They are going to cause the sympathetic neurons to be stimulated. And when they are stimulated, they increase muscle contractility, they increase sweating, they increase dilatation or mydriasis of the eyes, they increase heart rate, blood pressure, and respiratory rate, resulting into what we call anxiety. Then we have seen in summary insomnia that low levels of melatonin hormone stimulates suprachiasmatic nuclei within the hypothalamus, leading to the inhibition of sleep and stimulating wakefulness, leading to what we call insomnia. So after looking at this this pathophysiology of these two conditions, we're going to see which drugs can we use to treat people with these conditions of anxiety and insomnia. And as we have seen, the major cause is low levels. We have seen the cause of this condition, anxiety, is low levels of serotonin, which we are abbreviating as 5-hydroxytryptamine. Then we have seen the second one is low levels of GABA neurotransmitter. So if these two neurotransmitters are low, they are the ones that are triggering anxiety. Then we have said for insomnia, it is low levels of melatonin. So on treatment, when we are treating these patients, there are only two ways to treat anxiety. Either you can get drugs that increase serotonin levels, or use drugs that increase GABA neurotransmitters, which is an inhibitory. These are inhibitory neurotransmitters. So when given, we are going to see we can treat these patients. Because as we have seen in this, that serotonin is the one that is supposed to stimulate GABA. So no serotonin, no stimulation of GABA. So we're going to see drugs which can increase these levels of neurotransmitters, to treat these patients. And among the anxiolytics, these ones we are going to call them anxiolytic drugs. We are going to categorize them into two, those ones that increase serotonin and those ones that increase GABA. So we are going to start with those ones that increase GABA. So let us begin with drugs. Classification number 1, drugs that increase GABA neurotransmitter in the central nervous system. And among the drugs, we are going to remember them by using a mnemonic triple B. We use 3 Bs, whereby B number 1 is for benzodiazepine, B number 2 is for barbiturates, and B number 3 is for bisoprolol. So those are the 3 Bs we use to increase GABA within the central nervous neurons. So we are seeing number 1 is benzodiazepines, and benzodiazepines, they are categorized into 3, whereby we have the short acting, we have the intermediate acting, and we have the long acting. Among the short acting benzodiazepines, we are going to see drugs like filazolam, and midazolam. So triazolam and midazolam, those are short-acting benzodiazepines. Then intermediate, we shall see oxazepam. We are going to see lorazepam. Then we can also see another one, alprazolam, as another example. We have another drug like alprazolam. So these are intermediate acting. Then the long acting, we have diazepam and we have chlorodiazepoxide. So these are the major 2 drugs under long-acting benzodiazepam. And what is their mechanism of action? The mechanism of action of benzodiazepines, we are going to see for them, they bind. We are going to see there is this presentation of the GABA receptor. So if we have this one as GABA receptor, these are the GABA receptors. So what happens? The GABA receptor is a pentameric receptor having 2 alpha, 2 beta, and 1 gamma. So we're going to see benzodiazepines, for them, they bind on the allosteric sites. They come and bind on the allosteric sites between beta and alpha. And when they bind, they increase the affinity. We're going to see that when benzodiazepines bind on the allosteric site, when this is benzodiazepine binding, so they are going to enhance the binding of GABA neurotransmitter so that the little GABA, which is present, can easily be bind, and when for it comes and binds on this GABA receptor, it causes opening of the chloride-gated channels, leading to influx of chloride ions inside the cell. And when chloride ions enter into the cell, it increases the negative charge inside the cell, leading to hyperpolarization. And when hyperpolarization occurs, this is inhibitory. It is going to inhibit the action potential from propagating, hence exerting the inhibitory effect due to increase in negative charge inside the membrane. So we are going to see, after binding to the allosteric site, these benzodiazepines, when they bind on the allosteric sites between the alpha and the beta, we are saying they enhance binding of GABA. And when GABA binds, it causes opening. It causes opening of chloride-gated channels, leading to influx of chloride, causing hyperpolarization, hence inhibiting. So when the GABA receptor, when GABA causes hyperpolarization inside the cell, meaning the sympathetic neuron is not stimulated, therefore there will be no increased respiratory rate, there will be no muscle contractions, there will be no diaphoresis, and no increased heart rate, what we are calling tachycardia. So we are going to see the end result, the adverse effects or the ADRs of benzodiazepine. It is going to be, one of them is they cause sedation, they can lead to memory loss, they can cause hypotension, they can lead to respiratory depression, and so on. Then there is also muscle relaxation or muscle weakness. It can also cause muscular weakness because they are shutting down the actions of sympathetic nervous system. So this is what benzodiazepines do. And these benzodiazepines, they are indicated to treat acute anxiety. We cannot use them to treat chronic anxiety, or what we call chronic generalized anxiety disorder, which we call GAD. So we are saying the indication of benzodiazepines is the treatment of acute generalized anxiety disorder. Acute, we cannot use it in chronic, and we have seen these are the side effects of benzodiazepines. So why do we use them in acute generalized anxiety disorder? Is because they act faster. So for someone who has acute and is in panic, is having panic attacks, we use benzodiazepine to bring the effects faster. That is what we can talk about. And among the benzodiazepines, diazepam is used both in anesthesia, is used as antidepressant, and at the same time is used as an anti-anxiety drug. So this is what we can discuss under benzodiazepines, which is the first class that increases GABA in the CNS to bind to cause inhibitory effect. So another class we can talk about is barbiturates. And these barbiturates, they are no longer used in treatment of anxiety. And we are going to see the reasons why they are no longer recommended in the treatment of anxiety. Why these barbiturates, for them, let us first give examples. Examples of barbiturates, we have short-acting like thiopental. Thiopental is one of the barbiturates that they are short-acting, ultra short-acting. Then we have those ones which are intermediate. We're going to see others like pentobarbital. Pentobarbital is another class of barbiturates. We have secobarbital. Then we can end up with phenobarbital. You can even call it phenobarbital. So these are the example. So the long-acting phenobarbital is long-acting, whereas pentobarbital and secobarbital, they are examples of short. intermediate acting, but pentobarbital is long, phenobarbital is long acting, secobarbital intermediate, then thiopental ultra short acting. We have even amobarbital, which is also small or short acting. This is ultra short, then amobarbital is short acting. Then these are intermediate, and this is long acting. So these are the examples we can see of barbiturates. And their mechanism of action, we're going to see also, they come and bind on the pentameric receptor of GABA. And for them, the barbiturates, they bind both on alpha 1, some can bind on alpha 2. But after binding, it is going to cause, for it to bind is directly. And after binding directly, it causes increased duration of opening. So it increases the duration of chloride opening channel. So we are going to see when barbiturates bind, they cause increased duration. What we have not told you, among the benzodiazepines, for them they increase the frequency of opening. For benzodiazepines, they increase the frequency of opening of the chloride-gated ion channels, whereas barbiturates increase the duration of opening. So means when they bind on the GABA receptor, causing the opening, so it keeps open for so long. And when it keeps open for so long, more chloride ions will enter into the cell or into the neuron, leading to increased hyperpolarization. So these ones, they cause much hyperpolarization by increasing the duration of opening after binding on the GABA receptor. And this type of GABA we are using is GABA-A receptor. This is an example of a GABA-A receptor, not GABA-B, but GABA-A receptor. So after increasing the duration of opening, this one results into increased hyperpolarization. And this hyperpolarization will inhibit the propagation of an action potential, hence inhibiting the effects of sympathetic nervous system. But we have said that it is no longer being used, it has been replaced by benzodiazepines. Why? Because barbiturates, they have small therapeutic index. It has a small therapeutic index, and because they have small therapeutic index, a little overdose causes high toxic effects, whereby the effects can lead to respiratory depression, and this respiratory depression can lead to coma and death. So it has a small therapeutic index, and we normally say the smaller the therapeutic index, the more toxic or the lethality is the drug. The drug becomes more lethal when it has smaller therapeutic index. So a little overshoot of the dose, you can lose the person. That's why it is no longer being used. And another reason why it is no longer being used, it induces many cytochrome P450 isoenzymes. And because it induces them, whenever they are taken with drugs like fluconazole, drugs like cimetidine, valproic acid, these ones, so it affects many drugs by inducing cytochrome. So when cytochrome isoenzymes are induced, meaning we cannot achieve the therapeutic index of these other drugs. And another note that we should never take them with alcohol, because even alcohol causes depression. So they should never be taken. So this is what we can talk about under barbiturates. Then lastly on this, we can also discuss on non-benzodiazepines before we conclude on the ones that increase GABA. So we can also discuss on the non-benzodiazepines which have been lately introduced. They have been recently introduced, the non-benzodiazepines. So this is C, whereby C we are going to see non-benzodiazepines. And these non-benzodiazepines include, they are beginning with Z. We have triple Z, whereby we are going to have Zepicron, we shall have another drug known as zolpidem. Then we have another drug known as Zalepron. So these are the drugs that we can see under non-benzodiazepine. There are three of them. Zepicron, zolpidem, and Zalepron are the new non-benzodiazepine. And these non-benzodiazepine, they selectively bind on the alpha-1 of the GABA-A receptor. They selectively bind on GABA-1, GABA-A of the GABA-A receptor alpha-1, and when they bind, they cause opening. They lead to opening of the chloride-gated channel, leading to influx of chloride ions. This one leads to hyperpolarization. Hyperpolarization. So this is the mechanism of action of these drugs, binding directly on the alpha-1 of the GABA-A receptor, leading to the opening of the chloride-gated channel, leading to hyperpolarization. And after doing this, these non-benzodiazepines, they have replaced the benzodiazepines because for them they have less side effects compared to the benzodiazepines. These ones do not cause memory loss, do not cause depression, and they do not cause respiratory depression. So they have replaced the benzodiazepines in treatment of anxiety. So these are the drugs which can increase, that is class 1, drugs that increase GABA. So class 2, we are going to see drugs that increase serotonin. We're going to see drugs which increase serotonin, which is also a neurotransmitter, 5-hydroxytryptamine. And among the drugs that increase serotonin levels, we're going to see class A. Example of class A, we are going to look at SSRIs. Then B, we are going to talk about SNRIs. Then lastly, we shall talk about C, which is buspro. So these are the classes we are going to discuss that increase serotonin neurotransmitter. And serotonin, selective serotonin reuptake inhibitors, this one is, if this is the presynaptic neuron releasing, if they release serotonin by exocytosis, in here there is what we call postsynaptic, and this serotonin comes and binds on the serotonin receptors. So what happens, they have also another transporter in here on the presynaptic neuron known as SAT. So whenever serotonin is released in the cleft, majority of it is uptaken, or it is reuptaken into the presynaptic neuron by SAT. So we are going to see the selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors coming inhibiting the reuptake of serotonin into the presynaptic. And when we block the reuptake, we are going to see accumulation of serotonin within the cleft. And we know that when serotonin when there is increase in serotonin, when serotonin is high, it is also going to activate GABA neurons, and GABA neurons will be able to inhibit. That is the mechanism for SSRIs and SNRIs, whereby they act by, these two guys act by inhibiting reuptake of serotonin, and after inhibiting reuptake, they increase the concentration of serotonin in the synaptic cleft, hence enabling the chance of them binding to the receptors, whereby they fire an action potential, which goes and also stimulates the GABA receptors that will inhibit the action of sympathetic nervous system. That is what we can talk about. And an examples of SSRIs, we have fluoxetine. You can see examples like fluoxetine. We can see another example like paroxetine is also an example of this. Then another example we can see is the fluvoxamine. And lastly, we can see citalopram. So citalopram, then fluvoxamine, paroxetine, and fluoxetine. These are examples of selective serotonin reuptake inhibitors, which inhibit the reuptake of serotonin, increasing the levels of serotonin in the synaptic cleft. And we are going to see that these drugs, they are the first line. SNRIs and SSRIs, these are the first choice treatment of their first choice drugs for treating anxiety. They have replaced both the triple Bs. Why? But they are used to treat chronic. For them, they are used to treat chronic anxiety, or you can call it chronic GAD, generalized anxiety disorder. Why? Because their action is longer. They take, like after being taken, they take 2 to 3 weeks to bring their effect on the body. So that's why they cannot be used in acute anxiety. So these ones are used in chronic anxiety. Why? Because of longer duration of action. They take long to act. Sometimes it is always 2 weeks to bring their effect. An example of serotonin epinephrine reuptake inhibitor, the major example is duloxetine. Duloxetine is an example of SNRI, which we can talk about in this session. Duloxetine. And we have said these two are the drugs of choice for treating chronic anxiety due to their long duration of action. So we cannot use them to treat acute GAD or generalized anxiety disorders. And we're going to see that these serotonin reuptake inhibitors, why are the drugs of choice? They have limited drug adverse reactions, whereby the ADRs for these two drugs, it is only headache. They only cause headache. They cause dizziness. Then they can cause dry mouth. And sometimes these guys can cause sexual dysfunction, which is a decrease of libido. It can also cause sexual dysfunction. but which can be managed. So this is what we can talk about. And the last one we can discuss in this session, is buspron. And this buspron is a 5-hydroxytryptamine agonist. But before I forget, I want to tell you that the benzodiazepines and non-benzodiazepines, the antidote is flumazenil. Flumazenil is the antidote. So in the case of benzodiazepine poisoning, we can always give an antidote known as flumazenil as an antidote to reverse toxicity caused by benzodiazepines and non-benzodiazepines. But there is no antidote for barbiturates, no specific antidote for barbiturates. So you can take note of that. If they ask you the antidote for benzodiazepines, that is flumazenil. Then lastly, we are looking at buspron, and this buspron, for its action is when it acts on the 5-hydroxytryptamine A1 receptors, it leads to increase of serotonin, and when serotonin is increased, we are sure that there is stimulation of GABA neurons, leading to the inhibitory effect. And this buspron and SSRIs are the drugs of choice we are using compared to benzodiazepine and barbiturates. Why? Because of their less toxicity. This one can also lead to headache, can lead to dry mouth, can lead to dizziness, but it does not cause many side effects like sedation, memory loss, hypotension, respiratory depression, and muscle weakness. So these are the drugs we can use for treating anxiety. Then lastly is that one which is used to treat insomnia, and that is only one drug which we're going to look at, which increases melatonin, and that is we can call it ramaration. Ramaration is a drug that is used to treat insomnia. This one can be used to treat sleep disturbance. Why? Because it binds to melatonin 1 and melatonin 2 receptors, hence increasing the levels of melatonin. So when taken, it can easily induce sleep. Whereas these SSRIs can also be used to increase or to trigger sleep. So this is the drug that we can use in case someone is having problems with sleep, together with the non-benzodiazepines. These ones can also be used to induce. In case for them they are short-acting, so they are used to induce sleep. That is treatment of insomnia. So this melatonin agonist, together with non-benzodiazepines, can be used to treat sleep disorders. Thank you so much for learning at Medical Sciences. May God bless you.